Hi, everyone. It looks like there are still some folks joining, but we're going to go ahead and get started with the introductions. Thank you so much for being here today. So my name is Marley Bradley. I'm a member of the ISTSS Education Production Subcommittee. The Public Information and Education Committee works to disseminate advancements in the field of traumatic stress to both ISTSS membership and the broader public. I'm very pleased to welcome you to today's webinar, Opening Access to Address Trauma and Treat PTSD in Primary Care. And it is my very distinct pleasure to introduce our presenter, Dr. Sheila Rauch. Dr. Rauch is a professor in the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine in Atlanta, Georgia. She serves as the Deputy Director of the Emory Healthcare Veterans Program, Director of Mental Health Research and Program Evaluation at the Atlanta VA, and Director of Scientific Programs at the Center for Visual and Neurocognitive Rehab. With nearly 25 years of experience, Dr. Rauch brings a wealth of expertise in examining biological and psychological mechanisms of change in the development and treatment of PTSD and anxiety disorders. She's particularly passionate about bridging the gap between research and clinical practice to enhance the effectiveness of proven treatments. Before we begin, just going to make a couple quick notes. Please be sure to use the Q&A feature today and throughout the presentation. We have time set aside at the end to review your questions. This webinar is also being recorded and it'll be distributed using the ISTSS website at a later date. And for those of you who may be wondering, most of today's slides will be made available following the webinar. And with that, it is my pleasure to go ahead and hand it over to Dr. Sheila Rauch.
Thank you, Marley. Thank you so much for inviting me. And I'm so happy to be here talking with everybody at ISTSS. So today I'm going to be focusing in on opening access to address trauma and treat PTSD in primary care. This has been an area that's meant a lot to me throughout my career. One of my first positions was actually working in primary care, mental health, and it's something that I really enjoy. I wanted to start off though by thanking the many people over the 25 years that I've been working in this area who have contributed in lots of different ways to the work that I've done in primary care. There's even more people than I was able to list on this slide, but I just want to say it takes a whole team to really make these kinds of interventions get developed and work better and better over time. So thank you to everyone who contributed to that. These are my current disclosures, and let's get to actually presenting. So we'll start off just by the scope of the problem. So trauma and PTSD, well, trauma is ubiquitous in life. Most people are going to experience at least one trauma in their lifetime. 70% of adults worldwide have experienced a trauma, and most of those people have experienced multiple traumas, an average of about 3 per capita in the worldwide epidemiological data. We have a worldwide PTSD prevalence of 3.9%. So that means most people will experience traumas and most people will actually recover from trauma without necessarily developing PTSD over their lifetime. We do know that about 5.6% of people exposed to trauma are going to end up with PTSD over their lifetime from epidemiological data worldwide. So even though most people who experience trauma will not have PTSD, that's still a huge number of people worldwide who do experience PTSD or who may have other issues after they've experienced a trauma. People who go through interpersonal traumas, we know are at the highest conditional risk of having PTSD. And even though that's the case, so things like rape or sexual or physical assault are going to put people at the highest risk of having PTSD. We do know that the actually most frequent trauma among people worldwide is traumatic loss of a loved one. So while the highest conditional risk is that interpersonal trauma, we actually have more people who have experienced traumatic loss of a loved one and then develop PTSD following that. I just want to highlight also that there are certain populations that are at higher risk. That includes people who have been sexually assaulted, people residing in military or conflict areas, military populations themselves, police, firefighters, people who have high frequency trauma exposures and high exposures to interpersonal trauma are really in that higher risk group. like I said, most people are going to naturally recover, but we do know that those who, following trauma, have less access to resources, including social resources, social support, mental health assistance, or other types of supportive contacts, are at the highest risk of PTSD over time. So I really wanted to highlight on this slide that PTSD and trauma are significant problems in the world. And they're problems that are actually so big, our mental health systems worldwide really don't have the resources now to handle them. And they probably never will have the specialty mental health resources to handle them. So what that means is we need to really start thinking creatively for how can we manage the mental health impacts of trauma on a population level. And that has led me over my career. I've really been thinking about how do we get what works out to more people in more settings where people are who have experienced trauma. When the pandemic happened, we started even thinking about that more because everybody was being exposed to lots of traumas. There were lots of resources that were being taken away, and it was a low resourced kind of setting. Lots of social support being taken away. So people were at a really high risk of having PTSD over time during that pandemic era. And that led Barbara Rothbaum and Naomi Simon and I to really think about what is a way to conceptualize on a public health level how to manage trauma in this type of a situation. So we developed this phased approach to COVID-19 that actually is a pretty relevant framework for how generally we can address trauma on a population basis. And one piece of that is it's important to think about trauma as having phases, and the interventions that we would provide may be different in these phases. How we provide these interventions will definitely be different in these phases. So there's that initial phase when people are exposed to a stressor. An initial phase, we call that. There's the, and that would be like from the time that the ongoing risk is still there, or you might have another exposure, that would be that initial phase. Then you have the post phase, which would be after that initial risk is gone, so the imminent risk isn't there, out to about 3 months where people are kind of adjusting to what's the new normal. That would be that post phase. And then there's the long-term phase, which would be, 3 months to many years after a trauma. And the interventions that we might provide or consider providing would be different in those different phases. In addition, there are different levels. So this would be from light touch to heavier touch, to the level that's not on this slide would be our current mental health systems, specialty mental health systems. So these levels really focus on what can we do in a very light touch public health way. What are the messages that we can send out on a systems level, whether it's our health system or our state government system? What are the messages that we can send out that are going to help people to maximize their recovery in a trauma situation? And then there's a self-directed level, and that's where people may self-assess and self-identify as wanting to do something, and what are the resources that we can provide to help, again, maximize their recovery in that kind of a setting. So those might be self-focused therapies, like the book that Barbara and I wrote, or the app that we have, or potentially PTSD coach on your own would be another one that would fit in that. And then you get to another level, which is those brief interventions that are therapist supported or specialty, or have some kind of support part to that. Those would be brief interventions provided in mental health care or in primary care or in integrated care, where we're doing smaller versions of what we know works potentially in that specialty mental health setting. And then the next level that's not on this slide would be then engaging with the current mental health system, whether it's outpatient care or mass care or inpatient care. So all of those are things to think about as far as what does the system need to do to address this high level of need in our population. What I'm going to focus on today is that primary care level. And primary care is a really critical piece of this systems level because most people, we know over many years of research, most people want to receive their mental health care from their primary care doctor. and they don't just want medications from their primary care doctor. Now, primary care doctors don't necessarily have time to do therapy. So a lot of systems and federally qualified health centers now are getting set up with embedded behavioral health providers who can provide these brief interventions very efficiently and effectively and give people options for both medications and psychotherapies in brief formats in their primary care office to get more people access to effective interventions. So this is actually the self-help intervention that Barbara and I developed. There's an app that's also connected to this that's really a self-directed emotion approach. The reason I wanted to highlight this as we're talking about primary care is this is really building on the same information that we know works, that's been demonstrated in prolonged exposure research over lots of years, and really taking those pieces that we know are the critical pieces and finding ways to get them packaged in a way that behavioral health providers can use it, that a person can use it on their own with just a book, that a lay provider may be able to use it. And those are really the ways that we can get these interventions out of specialty mental health and to the people who need them on a much wider level. One piece that's important for that, though, is really focusing our message on looking for ways to integrate emotion approach into our cultural milieu. And that's really a theme through all of what you'll hear me talking about today, is really focusing on how emotions aren't dangerous and how approaching emotions is actually the way to work through them and go get out the other side to a healthier way of managing your affect and being in the world and thinking about yourself and the world. So back to primary care. Most people want to get their care in primary care. We know that rates of PTSD in primary care are higher than that 3.9 that I showed you on that initial slide, that for the general population in the world. Most of the research suggests it's about 12.5 or 11% in civilian primary care, and much higher than that, as you would expect, in a veteran population where they're having more of that combat trauma exposure. There, it's about 24% of veteran primary care that would meet for post-traumatic stress disorder. So this is a real opportunity to get patients access to effective interventions right there in that primary care setting. And that's often what patients actually want. They don't want that referral to specialty mental health. They want it as soon as they recognize that PTSD is an issue and they come into their primary care doctor, they want relief in that moment. They want relief then. They want some kind of hope, message of hope provided right then, not necessarily a referral. We also know another reason why PTSD is important to address in primary care is that it's highly related to other medical risks and medical conditions, including heart and lung disease, diabetes. Chronic pain is super high in patients that have post-traumatic stress disorder, and being able to address PTSD right in that setting, in that population, can reduce those risks and reduce those healthcare costs significantly. So there are some brief PTSD interventions in primary care now. When Jeff and I started this many years ago, there really weren't effective PTSD interventions for primary care, certainly not therapies for primary care. Now we've actually, Kyle Pasamato did a really nice study with PTSD coach, therapist-supported PTSD coach, showing that it can be effective compared to treatment as usual over 8 weeks. She showed that self-report PTSD was significantly lower than Tau. The CAPS ratings were not as clear, but they did see reliable change in about 34% of the PTSD patients and 18% of the Tau with just the PTSD coach. So these brief interventions can work. And what I'm going to focus the most on today is processing emotions in primary care, which we used to call prolonged exposure in primary care. This is the brief PTSD intervention that Jeff Seagrang and I developed, and with lots of help from lots of other people. This intervention was created because Jeff was a deployed Air Force psychologist, and he knew that there were lots of people with PTSD in his primary care clinics, and they didn't want those referrals to specialty mental health. They wanted PTSD treatment right there in primary care. So he said, how can we do this? How can we get prolonged exposure into this primary care setting, provided in a way that it's going to work? So it came from the need of the patients and the desire of the providers to get that into the clinic. And we created together in an iterative program working with those embedded BHOP providers. We ended up with the PE primary care model that you're going to hear a bit about today. It was modified back and forth by those providers so that it fits right into their practice. It's 30-minute sessions, you'll see. It's very simple. It's very workbook based so that the patients can take the workbook and work through, read through the same information that they're provided in the sessions by the provider. And it's very flexible. And currently it's in use in VA and DoD and federally qualified health centers with lots of good data showing that it's working well. So why processing emotions in primary care? Because most people with PTSD will never seek treatment for PTSD. So being able to have models of care at every potential open door, every potential site where someone will recognize at first that they have PTSD is going to be in our best interest, because that's going to get more people access to that care quickly, right away, something that works so that they get that response right away. You don't have you have much less of a chance of getting resistant to therapy if your first attempt at treatment is successful. So most people will never even get there. And then those that do get there oftentimes will refuse treatment, or they'll refuse that referral to specialty mental health, or they drop out early. So we want to be able to have an intervention that's right there, that's quick, that's easy, and that increases that reach of what we know works for treating post-traumatic stress disorder. We had an RCT in military populations, as well as one in the VA population, and some pilot data in our civilian primary care that all show that PEPC is working better than treatment as usual. So that's super great to know that it's going to work. And then I'll also show you some data from our training program that's a much larger sample, seeing how it works in VA settings. So the components of PEPC are the same components that you get in the full PE, only in a much smaller dose. So you get the memory exposure and processing that's provided in a written memory exposure that I'll show you in a moment, and processing questions. Most of the sessions, the 30-minute sessions that the provider will be working with the patient, most of those sessions are also focused on that processing. You also have that psychoeducation component, just like the big PE, that's provided in small bits in the sessions, but also in the workbook that the patient's reading. It's reinforced in that workbook. And they also do have in vivo exposure. What's different in the in vivo exposure is we call it taking your life back from trauma, and it's taught as a skill instead of taught as a whole hierarchy that you're working through. So it's one or two people, places, situations that you want to take back from PTSD. And then the provider is really talking about it as, once you've worked through these two, you can think about what other situations, people, places that you want to take back, and use this tool to do that on your own in your life. So the protocol is 4 to 8 30-minute visits. It's built in that primary care mental health model, or that behavioral health mental health model, where it's a brief assessment, contact zero, very patient directed, very focused on the patient is coming in, they're saying they're haunted by a memory. You're doing probably a PCL and just a brief check to make sure that they're not abusing substances or suicidal. And then if they want to get started, then you're getting started there with the PTSD work. And you're providing them those treatment options very briefly, brief psychoed starting in that context zero. By contact one, you're already providing them that patient workbook where they're going to write out their identified target trauma right after that first session and write their processing questions. And then they'll be reading their narrative that week. They come back contact 2 through 8. and do that same thing. So they read their narrative once in the session, answer those processing questions out loud, and then the therapist and the patient are talking through the processing, and just like you would in a full PE session, you're basically doing that processing piece. And then you talk about their in vivo and move on to the next session. I do want to highlight though, with these kinds of brief interventions in primary care, remission is not necessarily the goal for 100% of all patients. So we're really giving this small dose, intending that it's going to be enough for about 20-30% of patients. It's going to be a start for another 20-30% of patients. And then that last chunk of patients is going to be split between the people who maybe want this, but you know right away this isn't a good fit for them. Maybe their substance abuse is too severe to do this in primary care. They need more time, or other reasons that they need a higher level of care right off the bat. Or they may do it, but they have a really hard time following through, and they're going to need more support from a specialty mental health provider. And as soon as a behavioral health provider in primary care notices that, they can start working on that transition, because we always want the patient to feel like this is a progression of in support of their care, not that they're failing in some way in these interventions. All right, so this is what the exercise itself looks like. In the book, it's part of it, it's not all of it. But basically they have the trauma start point and end point, and then write your traumatic memory. And then they've got processing questions afterwards. So there is psychoed before this that kind of describes how they're supposed to write their memory and what's important, including that emotion and those kinds of things. But in the end, they get this and they write it. So who can benefit from PEPC? Anyone who's experienced a trauma and is reporting that they're currently haunted by a specific memory of a trauma, and they want to work on it right in primary care. As long as they don't have imminent risk to self or others, or they're abusing substances to a level that I'm concerned for their safety, then I would be willing as a behavioral health provider to actually get started with them and follow measurement-based care to see if this is working or not working, if we need to change direction or change the treatment plan based on their response. So our pilot study, we showed really nice results and a good effect size for about 1 for a year out. What was important here for Jeff and I was really that we're not giving people, half PE. We're giving people a really good dose, and for some people, this is going to be a remission for them. And then for other people, it may not be enough, but we can connect them then to a higher level of care to continue the work that they start with this primary care intervention. So what does this look like? Let me show you a brief video. So this is from the training videos. You'll see this is an actor and me, but it's based on patients who we've actually had.
Okay. So
Actually. Okay.
all right, Susan. So we've talked about the how of approaching the memory with the written exposures.
Can people hear it
Now
okay?
I'm going to actually show you the forms.
That sounds great.
So this is what I'm going to ask you to go through and write out the memory of Sergeant Smith on these forms tonight or tomorrow. I'm seeing lots of concern in your face. Can you tell me what's going on?
I don't know that I'm going to have time to do this tonight.
Okay. So it's fine to wait until tomorrow to do it, but I'm sensing that there might be something more there.
Well, I've got kids at home, and I just don't know that writing it all out and it's going to get me emotional, and I don't want to do that in front of them.
Okay. Well, that emotion is what we need. That's what we want you to start approaching and connecting with. You remember we talked about the hot potato and how that trauma memory right now is like a hot potato because you're pushing those emotions away and it just stays very hot with intense emotion. What we're going to do with this treatment is actually approach it, feel that heat for a little bit, that emotion for a little bit, let it dissipate, let it get less over time so that hot potato has a chance to cool. And you remember that that's the way to move through the memory so that you can be in control again instead of having that memory controlling you.
I just think that whenever if I do this, then it's just kind of guaranteeing that I'm not going to get any sleep, that I'm going to have nightmares. And I've got a lot going on at work and I'm trying to keep things together. And I don't know how I can keep it together if I'm trying to write it all out.
Okay. So I'm hearing concerns about your time. We can figure out a time, like a 30-minute window when you can work on the memory, you can approach it. I wouldn't say to do it right before bed because that is not good. And lots of people will have trouble with sleeping if you do it right before bed. So when we get to the end of session today, we can talk through when would be a good 30-minute bubble that you can have, maybe when your husband can watch the kids and you can just focus on yourself. And you remember why we're doing this is really so that you can have more resources, have more emotional energy for work and for family and for all that other stuff that's going on. Because right now that PTSD has taken a lot of those resources away.
Yeah.
So are you thinking you'll be able to do it tomorrow? It sounds like would be better for you.
I don't know that there's going to be a good time, but I'll do my best.
Okay. And it might be hard. That's okay. Approaching the memory is going to be hard in the short term, but hopefully better in the long term. I know you can do this. And if you need help, you can reach out.
Okay, thank you.
So that's just a little snippet for what PEPC looks like. So you'll notice it's much quicker. It moves faster, like most brief behavioral health interventions. It's very patient directed. So we're starting with the patient coming in and what they're saying that they want to work on, and going with that. And if we're meeting a lot of resistance, then I'm probably going to be referring to a specialty level of care where they can have more time to talk through situations and what's going on. Let me share my slides again. All right. And this is the first RCT that was done in military treatment facilities, where we compared prolonged exposure to minimal attention control over 4 to 6 weeks. So patients were randomized to get PEPC right off the bat, or PEPC in 6 weeks and minimal attention for that first 6 weeks. So what you can see here is we had significantly lower PCLs in our PEPC group at 6 weeks compared to the minimal attention control. And then what's also important is when that second group got PEPC after the minimal attention control. First of all, everybody who is in the minimal attention control still wanted to get PEPC. So that tells us feasibility as far as patient wanting it. And then we also see that same slope of the line when we apply the PEPC. The last important thing on this circle is that those symptoms reductions were maintained out to 6 months later. So it's not just that things are temporarily getting better and then they're going to get worse again. They're actually getting better and staying better, like they do when we do a full PE or a full CPT with the patient. So that's wonderful, and really we couldn't have asked for better findings in that initial study. Since then, we've been working on training programs in the VA, in the DoD, and now in civilian settings. And this is actually data from our first 2 training cases from providers in the VA who are being trained in PEPC. These are just demographics, but it just shows you that these are regular primary care patients across the VA. It's 733 first and second training cases. What we found was it took about 5 sessions on average for these patients to be considered completers or done if they were going to be completers. We had about 85% of that sample who had PTSD according to PCL at baseline. So it's not necessarily required as long as they have some symptoms and they're saying that they're wanting to address those symptoms in primary care. But even though we didn't require it, it was still a majority of the population who did meet according to PCL. I also want to highlight that this is a very veteran-centered intervention. So if they're not raising their hand for care, we're not pushing this on them. And the flip side of that is if they're raising their hand and we don't have a really good reason not to offer it to them, then the general stance is that we're going to offer it to them, let them do it, and follow the measurement-based care to see if their symptoms are changing and change the treatment plan if they're not. So we have about a 64% completion rate in that primary care setting. A lot of these are patients who have never, this is their first episode of care for PTSD symptoms. So that is especially, I would say, especially impressive to have a 64% completion rate with that. Clinically significant change in 32% of all the veterans who started PEPC, and we operationalize that as at least a 15-point change in PCL. We also had 81% of those veterans who were clinically depressed at baseline no longer met that clinical depression cut on the PHQ-9 at post-treatment. So it is addressing depression among those patients who have depression at baseline. I also want to highlight here that referral to specialty mental health is not a bad outcome for PEPC. If we're starting people in care and then they're more willing to take that referral, that's wonderful. That's a win in our book and in how I train everyone in PEPC. So overall, in these first 2 training cases, they have an average PCL reduction of about 9 points. The PHQ-9, again, this isn't a depression treatment, but for those who are clinically depressed, it does address those depression symptoms in 81% of the patients we saw on that last slide. So these are significant reductions in PTSD and depression. And for PTSD, it's a moderate to large reduction overall. What's also important with this large sample of VA patients, we looked at predictors of magnitude of change to see whether there were any mediators or moderators, and we really didn't find, we looked at the usual suspects, we looked at gender, race, ethnicity, trauma type, provider training, meaning was the provider previously trained in PE or CPT, or were they fresh and new to trauma treatment, and age of the patient in depression. And none of those things actually predicted magnitude of response. So that's good. That suggests that it's a very robust treatment that's providing good effects across different racial, ethnic, gender categories. When we look at retention, we did see some impacts. Older veterans had better retention. That's similar to full protocol PE or CPT studies. Providers with training in both PE and CPT had better retention. I think that variable is probably a marker for people who have more experience with trauma. And those people who have more experience working with trauma are probably better able to retain patients. And that's an area in the training program now that we're kind of trying to target. Can we move this? Can we help people focus specifically better on retention? We also saw that MST target trauma had a lower retention, and Asian and Pacific Islander veterans are actually better retained than other groups. However, I qualify that because that wasn't a very large sample of Asian or Pacific Islander veterans. So anyway, so that is important to know. Rebecca Shripata has been leading a series of studies in federally qualified health centers using PEPC and has found in that population even larger effects. With the initial pilot study in 30 civilian patients with PTSD, our baseline PCL was 59.8, dropped all the way to 44 in 2 months, and then was maintained at 41 out to 4 months later. So that's a very large reduction in PCL maintained over time. And these are some really nice statements from the qualitative interviews that they did with patients and providers in that study. You can see the patients recognize that this was hard, but that they felt like it was helpful and useful, and it helped them to take their lives back. So these are really nice testimonials. It seemed to help more than other treatments I've had because it was more focused and targeted. It was intense and short, but it got to the point. And that's what a lot of patients who really do well in this treatment, that's what they'll say, is that it was quick. It may be hard, but it was quick, and I got a lot out of it. Provider perceptions. So these are people working in federally qualified health centers are really finding it useful to have a PTSD tool. So social workers are 3 months out for accepting patients for therapy. I definitely need more tools to deal with trauma. These are providers who want something, and we were able to give them a new tool that they found was helpful and useful in their practice. So Becca Dr. Shripata is now doing a larger study called Transform. That's a smart design study that's comparing stepped approach to address PTSD, looking at clinician-supported PTSD coach and PEPC, and then stepping up to full PE. I don't have results for that now, but I just want to highlight that that study is going on. This is the overall design, and we'll have some really interesting results, I'm sure, in the next few years based on that. So from my VA RCT, I looked at trajectories of change in PEPC because I want to be able to figure out I don't think that PEPC is 100% answer for 100% of patients. And it would be really nice if we could know initially, like at the baseline, who is this going to be the right treatment for and who should we refer on right away. This study did not give us that answer wholly, but it at least started helping us see some factors to look at. So basically we looked at the patients who received PEPC and what were their trajectories of change, and then could we predict from baseline variables those trajectories. And we had 2 variables. So the primary outcome in this study was actually function on the HUDAS, not PCL. But we looked in the trajectories at PCL and we looked at HUDAS. So you can see here, we have 4 lines. It's actually not, it's about 25% of the population in each of the lines. So that red line are the people who did really well. So they're the ones who are remitting. That's about 25% based on this PCL with this trajectory analysis. When we look at function, we get a larger percentage who are actually showing that clinical response in the HUDAS. In function, we have about 39% who are showing that blue line here. Oh, sorry. On both of these, I also want to point out that that yellow line is the only line where we think that there may be some increase in symptoms. So that's also something that we're wanting to look more specifically at if that replicates in a larger sample, because we would definitely want to be able to pull people who may have exacerbation with the brief intervention into a higher level of care more quickly. So here we can really see in function, we're not seeing any exacerbation. So people kind of are either staying where they were or they're getting benefit. So that's encouraging there. When we went to look at predictors, we looked at age, race, sex, study site expectancy, meaning the patient's expectancy for whether they thought the treatment was going to work well for them or not, credibility, whether they thought it was a real valuable treatment or not. And none of those things actually predicted trajectory. The only thing that significantly predicted trajectory was the baseline PTSD severity. The HUDAS and depression did predict, but once we controlled for the baseline PTSD, they no longer contributed to the model. So it's really that baseline PTSD that seems to be predicting the trajectory. When we looked at function, we found a similar pattern except with function. So function predicted itself, the baseline function predicted the trajectories across, but depression and PTSD contributed until you put them all in the model together, and then function really drove the train. Okay, so I do want to highlight some limitations to this study. The first is that it was a small sample size. It was only 69 patients. 59 patients. So we do want to replicate this, and we're currently working on that in our larger sample from the training program, the retrospective study from the training program. So we're actually looking at those trajectories to see whether we get those same patterns or different patterns, and whether we're able to actually look at some predictors within that model. I also want to highlight that my RCT was done at a single site, so we don't know if it was site-specific issues or if these trajectories would be the same at other sites. And then we also don't know outside of VA. So will a civilian sample have the same trajectories? We don't know. The civilians seem to have larger magnitude of response to the PEPC intervention overall in the studies that we've done there. So they may have different trajectories. So overall, just to update where we are, about 25% of veterans show sustained remission of PTSD with the PEPC intervention. 39% show sustained functional improvements with PEPC. It's providing increased access to effective PTSD care to a much wider group of patients. It reduces burden of care on the system. So instead of 8 to 15 90-minute sessions, we've got 25% of people who are remitting in 4 to 8 30-minute sessions. That's a huge reduction in the cost of care, the burden of care on the system. For those veterans who present to primary care with higher severity of PTSD, as we saw in the trajectories, or higher functional impairment at baseline, we may want to really focus on timely referral to specialty mental health. But I say that with a little bit of a qualifier, because I don't think we should require people to do that. But as a system, if we're able to get them set, if they're higher on that severity, get that referral to specialty mental health set up so that if they need it, it's there and they can go right into it. What I would not want to do is to have someone raise their hand in primary care saying that they want treatment for PTSD, and then we say, oh, you have to wait 3 months, when we could potentially get started with PEPC in the primary care setting and then move them over if they needed it, if they needed the higher level of care. So we do need to interpret the trajectories with caution. They need replication, and we want to stay veteran-centered and make it all an interactive discussion of treatment planning to bridge that transition to care. So what is our status of implementation of PEPC? I'm very proud to say we have 409 VA providers who've completed PEPC training as of June of 2025. We currently have 43 people in training now. We have providers in every VISN and 233 different facilities. We have 18 active training consultants and 29 consultants who have been certified to date. 15 DoD providers, and 1 is currently in training, and 59 civilian providers trained in PEPC, with 12 currently in training. We've also moved a model of this into employee assistance programs. Rebecca Shripata is leading that project. And so there are 32 counselors and EAPs trained in PEPC, and 22 civilian providers trained in that transform study that you saw as well. So those are in FQHCs. So we're getting this out. We have a really efficient training model that fits into the practice of providers. It was designed with the providers' input and fits into their practice in that way. So here's information on the training program. I'm not going to talk a lot about it today, but if you're interested, you can reach out to Margaret Venners in the VA, or if you're outside the VA, it's James Garlick at the University of Michigan. And I think we have time for questions now. I see a hand raised, and then we've got the Q&A. Should we go with?
I'm not sure if we have the function enabled to allow our audience members to speak. So for the person who has their hand raised, it might be best to go ahead and drop your question in the Q&A. And there was a lot of great questions coming through. It might be best to kind of go one by one on these to start, Dr. Rauch.
Okay. And I'm actually not seeing the Q&A in my, oh, here it is.
Okay.
Okay. There we go. I got it now. Sorry. Do you want to go through them, Marley? Do you want to like say the question and I can answer them?
Sure. Absolutely. So the first question was just somebody wanting to know a little bit more about rates of trauma and PTSD among healthcare providers. So due to very chronic and significant vicarious trauma exposure.
So off the top of my head, I do not know what those rates are. I do know that for people who are working in ERs, I would suspect that it's higher than other populations, but I don't know off the top of my head what the rates are for healthcare providers.
There were quite a few questions coming through about assessing goodness to fit in this case. So this person asked, what does your intake process look like to ensure the client is the right fit? I assume client will need to be in the preparation stage of change at minimum. And also this person wondered what makes this treatment distinct from CPT.
Yeah, so great question. So as far as the intake, that since this is integrated behavioral health or a PCMH program, depending on whether you're VA or outside of VA, it's focused on brief functional analysis generally is the intake. So it's a very fast-paced asking the patient what are the issues that they want to focus on, and then making sure there aren't contraindications like alcohol or substance abuse, risk for suicide, family abuse, access to firearms, those sorts of things that you might want to pay attention to. But for the most part, if the patient is coming in and saying that they're interested in focusing on a trauma that's haunting them and they're not psychotic or abusing substances, as a behavioral health provider, I'm going to probably go ahead and get started with them and continue to monitor symptoms with measurement-based care. If something changes or if other symptoms become more apparent as we're working together, then we would change the treatment plan based on that.
Another person wondered if there were special or any considerations for patients experiencing ongoing chronic or complex traumatic stress, such as those living in poverty or those who have multiple traumatic events, specifically because this is a population they often see in primary care.
Yeah, so that's an excellent question, and it is very complex. So generally, I'm wanting to empower the patient that's there with me. If they're currently in a situation that's dangerous for them, then that's going to take priority before we're, as much as possible, I should say, working with the patient. I want to get them as safe as possible, as stable as possible, and that's going to be different for different populations that you're working with. And then everything is collaborative. So when you have them as safe as possible, then it's working with them to say, now you feel like you're in a place where you want to do this now. And if their answer is yes, then you're working in that situation. For example, right now I'm consulting with someone who's working with actually quite a few homeless people in the Atlanta area. using this intervention with that population. And so we're regularly talking about safety and how safe are they and what can we do to help scaffold their safety. But we're also talking about privacy. And if you're writing this out, where are you going to keep it that's going to be private for you in your current living situation? Do you want to keep it on your phone? Do you want to, so those sorts of issues. And it'll be very different for different patients. I don't like to set lines to say you can't have this because you don't have a roof over your head. If someone has PTSD and they feel motivated and they feel safe enough to do this, then I'm going to want to work with them to help them take their life back from trauma.
Another person was curious whether this model has implemented in any low or middle income countries, and also whether there's potential for this type of treatment to be implemented by trained supervised lay providers.
So yes and yes. I'm currently working in South Africa, so it's a middle income country, but we're working in an area that's highly traumatized, very low income area in South Africa. And in that population, we've actually worked with lay providers, and we've worked with entry-level graduate students, providing the intervention with the support of a psychologist. And we've gotten really good results. I've really enjoyed the lay population there that is super passionate to get these resources out to their communities, and being able to just hear the life stories of most of those individuals are people who have experienced trauma themselves, and then using this intervention and feeling empowered for themselves and also empowered for their communities to be able to have a useful resource. So, and Dwayne Buisen is leading that work in South Africa.
Awesome. Another person had a question about assessing whether someone's a good candidate, but I feel like you covered that really well. But they were also curious how you might approach a client who doesn't feel ready to do exposure, but doesn't want to disengage from treatment in this setting.
Yeah, so using a functional analysis in behavioral health, I would probably find another target to work on treating. So if they wanted to work on sleep, you could work on sleep. If they wanted to work on depression, you could work on depression. So I'd probably just look for another brief target to focus in on, and go from there. The other option would be if they wanted, I might talk with them about a higher level of care if really PTSD was the biggest thing driving the train and it was avoidance that was making them not want to do this with me in primary care, then we might have that discussion as well.
Another person asked, and this might have been related to one of the studies you were reporting on, but whether you differentiated their trauma history with moral injury and whether there was any indication that PCPE is effective for folks with moral injury and PTSD.
So I have not looked specifically at moral injury in this population. I would say though that the work that I've done in regular PE with moral injury, if PTSD is the diagnosis, then generally moral injury, PTSD responds as well. If it's moral injury, but the primary presenting complaint is depression, then this may not be the right treatment for that. But if PTSD related to moral injury is the presenting complaint, then I would expect PEPC to be super effective for that.
Another person, this can maybe be more of an implementation question. They said, for these studies, how many mental health professionals do you have working together when offering this treatment? How often do consultations happen and for how long? For some primary care settings, there is one mental health professional doing intake, care coordination, brief counseling, and group programs, limited support being offered.
Yeah, so it varies a lot. And Dr. Sripada would be much better able to tell you all of the variety of different sites. But I know some of our sites have 2 or 3 providers. Some of our sites have 1 provider. All of them, when they're in the study, they get trained in the interventions. The PEPC training is very brief. It's 6 hours and then 30-minute phone calls, group consultation, 30-minute weekly calls. And people do really well with that. So that tends to be what we do, and it tends to work pretty well across different environments. I will say if someone's in an environment that's really hostile towards evidence-based care, that's going to make any implementation hard. Yeah, but it does come up.
And I'll just quickly mention that Dr. Sherpada dropped into our other chat that CS PTSD coach training is 4 hours and the full PE training they provide is 9 hours, just so we all have that. But some folks did generally have questions about kind of the breadth of how this can be implemented. Somebody asked whether it's been studied in group format. Another person asked about whether it can be used with teens and children. And then another person asked if there have been any Spanish translation work.
So I love the excitement. So as far as adolescents and kids, that's not an area that I do a lot in. So if someone wanted to take this and modify it for that, that would be wonderful. It has not been tested with kids or adolescents, but I would suspect, just like the adolescent version of PE, that we could probably do a nice job of modifying something for that. The other ones were, what were the other ones?
Oh, sorry. Whether it's been adapted for Spanish language.
Oh, yeah, so it's been translated into Spanish. We do have Spanish provider and patient manuals. Yeah, and I don't have separate outcomes data with the Spanish version, but we do use that in the VA quite a bit and in the civilian setting.
And then the other one was whether or not this has been studied or whether you might think it's appropriate for group format.
So we have not looked at this in group format. I don't know. I mean, I think it would be an empirical question. I love getting things more and more efficient. I do think that there would be a place where it would be too little of a dose, but that again would be an empirical question. You could probably do parts of it at least in group format.
Well, I know we're getting down to the last minute here in the webinar. So I just definitely want to thank you again, Dr. Rauch, for sharing your work with us today. I think we answered most of the questions in the chat. Some folks did have questions about how they could become trained. So love to see that excitement. I know that you mentioned it in your slides. So I assume it'll be available as well later when the slides are made available.
Yep, it'll be in your slides and it's here too. If yeah. Those are the emails, and then my slides will be here. Thank you, everybody. Thank you so much, and thank you for the great questions as well.
Thanks, everyone. I hope we'll see you again at another webinar soon.